My name is Dr. Carolina Sueldo. I am double board certified in both OBGYN and infertility. So the term is REI, or reproductive endocrinologist and infertility specialist. I've been practicing for almost a decade now. When I finished training, I first started in South Florida at a large group, and then in 2018 I moved to California, where I worked in a physician-owned private practice, and then I also taught residents for UCSF Fresno. So I teach the medical students and residents for that program still to this day. It's where I trained originally. It's my alma mater, so very proud to be part of that program. And in 2023, I moved back to Florida, so my family and I relocated to Fort Lauderdale, and we opened doors to Ceibo Fertility Center. And Ceibo opened its doors really with a tagline of fertility care reimagined. Our deep belief that, cutting edge technology and good success rates does not have to be at the cost of patient experience, and really wanting to bring back the doctor-patient relationship into medicine. You touched on a few things that I talk a lot about, which is really sort of the lifestyle optimization component. What are variables that the patient can control in their infertility journey, along with integrative practices. And there's many of them out there today that really, when done consistently, and by providers who are experienced in what they're doing, can really be a great adjunct to care. So, we have been now open for a little over a year. And are continuing to grow. So very excited for Ceibo's footprint in South Florida to continue to grow, offering patients an alternative in this space. Absolutely. So PCOS is probably one of the most common diagnoses that I see in my clinic. PCOS stands for Polycystic Ovary Syndrome. And unlike the name suggests, it's actually not cysts on the ovaries. So that's what most women think when they think of PCOS. It's actually an egg excess disease. And so what we see is that typically you'll have an enlarged ovary with a very, very abundant follicular or egg count. Inside of that ovary, we tend to see high estrogen, high levels of testosterone being produced. And so that is then going to have implications on the rest of the body. There's some question about sort of why does PCOS happen? What is the cause? Is the cause at the level of the ovary that I just described? Is the cause genetic? Is the cause at the level of the brain? So those would be the hormones that regulate the ovary, or talk to the ovary about when it's time to produce one hormone or another. Or is it lifestyle? Is it environmental? And, so far the literature suggests that it's a multifactorial disease. So there's really not one specific thing we've been able to pinpoint, but rather there's probably a genetic component, there's probably this hormonal component, there's probably an environmental component as well. When we talk about how common PCOS is here in the US, the CDC quotes somewhere in the ballpark of about 13% of reproductive age women. So it is the most common hormone disorder of reproductive age women, or reproductive hormone disorder in reproductive age women. So really much more common than people think. When we talk about what is PCOS, like how does it present, we typically see a woman who comes in complaining of irregular menstruations. So maybe she's skipping months, maybe she's not getting her period at all. They may also have clinical or laboratory signs of elevated testosterone. So think of things such as head hair balding, acne on the chin, chest, or back, hair on the chin, chest, or back in a male distribution pattern. So those are the typical presenting complaints. I will say it's a lot more complex than that. Before you're even starting to think about building your family, PCOS typically tends to present in late adolescence or early adulthood. So think about late teens, early 20s. And when we talk about PCOS, we really are talking about reproductive symptoms and then non-reproductive or general health symptoms. And there's a whole host of them. When we talk specifically about the reproductive ones, so I mentioned the irregular cycles or skipping cycles, maybe not getting your cycle, that may also be coupled with heavy periods. So when you do get a period, it's extremely heavy, it may last a long time, they may or may not have pain associated. So cycle irregularity, cycle flow irregularity, all of those things can be reproductive symptoms of PCOS. The underlying reason for that cycle irregularity is that they're not ovulating. So lack of ovulation or anovulation. And so what happens when patients come to see me is, hey doc, I'm trying to get pregnant, I'm skipping cycles, or I'm using the ovulation predictor strips and they're not working for me, or I have an app and the app totally is, all over the place with when my cycle is coming. So that is typically what I'm seeing, and it's due to the lack of ovulation that goes along with PCOS. If those patients become pregnant, they are also at increased risk for pregnancy complications. So things such as increased risk of miscarriage and other risks such as pregnancy hypertension, pregnancy and diabetes. So there's a lot of things that can come along with that. But PCOS should really be understood as a systemic disease, not just affecting your menstrual cycles. It really does have many general health or non-reproductive symptoms. So for example, there is published data that suggests that women with PCOS, 50% of them will develop diabetes by the time they're age 40. We know that there's another study showing that 70% of them, so if you have PCOS, 70% of those women have abnormal cholesterol, so high cholesterol panels, typically requiring early intervention with medication. Sleep apnea, that's another one that's really common. Psychosocial disorders like depression and anxiety, those are much more common in women with PCOS. And we don't know in that scenario, is it the hormone imbalances that is triggering those mental health issues, or the reverse, right? So chicken or the egg type of thing in that scenario. But significant risk for cardiovascular disease, significant risk, I mentioned diabetes earlier, the sleep apnea. So there's a lot of systemic general health components to consider when we're talking about PCOS. Patients may also report that they have difficulty with weight gain, and even though they're working out just like they were before, they have difficulty with weight loss. And again, we don't fully understand the mechanism. Is it tied to the underlying insulin resistance? Is it having to do with some of those hunger and satiety hormones like leptin and ghrelin? So the data is a little unclear about the why, but it is definitely something that we see in PCOS. The one last comment I'll make, and I went a little bit further than maybe we wanted to, but I do think it's important that when you Google PCOS, like you Google a PCOS woman, you will typically see a woman that tends to be obese, that tends to be very hairy, that tends to have significant acne, and tends to have darkening of the skin folds. And that is one type of PCOS, but the NIH, the National Institute of Health, actually describes that there are 4 clinical presentations. There are 4 different types of PCOS. So just because you Googled PCOS and you don't see yourself reflected does not necessarily mean that you don't have it. Great question. So, if you look at the history of how PCOS was diagnosed, that answer has evolved over time. So the more we learn, that answer changes. What I will say is that in the early 2010, 2012, somewhere in that era, a bunch of experts got together in Rotterdam and they said, hey, let's come up with unified criteria so that we can talk about the same thing when we're doing research studies to talk about PCOS. So we had, the NIH criteria, we had the Androgen Excess Society criteria. The Rotterdam criteria emerged as sort of the most widely accepted way to diagnose PCOS. And the way that I educate my patients is you have to think about PCOS a little bit differently. When you think about diabetes, for example, we're looking for a certain cutoff of sugar or a certain cutoff for the hemoglobin A1C. When we're talking about high blood pressure, we're looking for certain numbers in that blood pressure reading to make a diagnosis. With PCOS, because it is a syndrome, right, Polycystic Ovarian Syndrome, it is a constellation of signs and symptoms. And so you really are trying to pick out, does this patient meet enough criteria to be able to arrive at that diagnosis? So the Rotterdam criteria emerged as the most widely accepted, and they talked about, number one, irregular or lack of menstrual cycles. Number two, the clinical or laboratory signs of elevated testosterone. And then number three is polycystic ovaries on ultrasound, and they actually gave specific markers, like how big does the ovary need to be, how many follicles or eggs do you need to see to be able to make that diagnosis. And then number four is ruling out other causes that could be contributing to the patient's hormone imbalance or irregular cycles. So think of things like thyroid hormone, prolactin hormone, severe uncontrolled chronic disease. So those types of scenarios, the patient may have irregular cycles for other reasons. So as long as you've ruled out other causes, then you need two of the three to arrive at the diagnosis of PCOS. Now in 2023, the International PCOS Network, they actually put out updated guidelines. And so it was a very lengthy document that was trying to basically take everything all the research that had been updated since Rotterdam was initially published and look at the last 15, 20 years to try to put together updated guidelines. So those three remain. The only addition now since 2023 is AMH, or anti-Mullerian hormone, which is a hormone that can be checked in blood, and it is a measure of ovarian activity. So women who have PCOS tend to have very high levels of AMH hormone. Now, AMH cannot be the only marker used to make the diagnosis, but it is now incorporated as part of that diagnostic workup. So that is how we typically diagnose PCOS, would be by blood work, looking at the different hormone panels that I mentioned earlier, and then by doing an ultrasound to assess the ovaries. The first thing that's important to understand is whether or not the patient is seeking pregnancy. So if the patient is not seeking pregnancy, you still need to actively manage her, but you're going to do it in a different way. Okay? So from a medical standpoint, I'll start there first before I get to some of the other things. So from a medical standpoint, a patient who comes in with irregular cycles who is not seeking pregnancy, we want to give them what they're not making. So when a patient is not ovulating, she is not making the progesterone hormone. And I actually have a great little diagram here that I'll show you. So let's see in my camera, pre-ovulation and post-ovulation. So post-follicle rupture, we have the corpus luteum. That corpus luteum hangs out in the body for about 2 weeks, and that is the main producer of progesterone hormone. So we know that progesterone is made every month for about 2 weeks. So if a patient is not ovulating, the corpus luteum is not being produced, and so all we're seeing is that estrogen activity. And when I talk to patients, I talk about a light switch. So imagine a light switch. Imagine estrogen is the on switch and progesterone is the off switch. So if you are producing estrogen or your body is seeing estrogen, those cells are constantly turned on. Specifically, the cells of the lining of the uterus, and again, a picture's worth 1,000 words, so I'll bring it up here. But this is a female pelvis. You see the uterus here. Inside the uterus is the lining. That is the tissue we typically shed every month with a period. So those cells, that lining, responds to the estrogen and progesterone hormone. So when you're making estrogen, you have that on switch. Those cells are active, they're proliferating, they're growing, they're trying to build in preparation to receive an embryo. If you don't have that off switch, right, so the off switch, which is progesterone, stabilizes that lining and keeps it sort of fluffy and ready to receive that embryo for pregnancy. So if you don't have that off switch and all you have is the on switch, those cells are constantly active, and they have the risk of becoming abnormal. And when I say abnormal, what I mean is precancer or cancer. The technical terms for those are hyperplasia or adenocarcinoma, so precancer or cancer. The youngest patient I ever saw with cancer of the uterus was 24 years old. She ended up having to have her uterus taken out. So if you remember nothing from today's conversation, is that you should be getting those regular monthly menses, And if you're not, and if PCOS is diagnosed and lack of ovulation is diagnosed, then we want to make sure that we're giving you what you don't produce, which is the progesterone hormone. And that can be done in any number of ways. There's pills, there's patches, there's shots, the progesterone IUD, there's many different forms to give progesterone. The most important thing is you want to be giving the patient that off switch in the setting of PCOS, specifically when ovulation is not occurring, okay? Now, if the patient is seeking pregnancy, then the goal is different. Then the goal is, how do we get her to produce that egg for ovulation so that we can see that menstrual cycle occurring, like I showed you in the image? And so what we use are ovulation induction agents. Ovulation induction agents are simply prescribed medications that are trying to overcome that resistance in the ovary to get the patient to produce an egg for that month. The first line therapy in the last 10 years has been a medication called letrozole or Femara. We also historically have used Clomid. Clomid since 2015 has really been more of a second line agent. Those are both oral medications. They're pills. They're taken once a day from anywhere from 5 to 10 days. And then we also have the option of doing injectable medication. So again, circling back to where we started, what is the goal of the patient? Is she seeking pregnancy? Yes. Then she needs an ovulation induction agent. Femara or letrozole, Clomid, or injectables. If she's not seeking pregnancy and she has PCOS with anovulation, then we need to give her what she doesn't make, which is that progesterone hormone. So that from a medication standpoint is like the most succinct that I could possibly make it. But I want to emphasize that there is so much about PCOS that can be managed without medication, okay? And I wanna be clear, this is not an either or. This is not a, oh, don't use medication because your PCOS will be healed with XYZ magical thing. No, they want to be working in conjunction. So this is, how do we optimize? How do we set the patient up for the best success in her treatment for PCOS? And so really at that point is where integrative practices come into play. And integrative practices is just this very big umbrella term that encompasses all things that are non-medical, so non-prescription, non-intervention, okay, or non-procedural, let me be clear. So when we talk about integrative practices, the first thing that I always talk to patients about is lifestyle. What's your nutrition like? Surprisingly, despite the elevated weight associated with PCOS, most of my patients are actually not eating enough. They're actually not eating enough calories. And usually they've struggled with weight most of their adult lives. And so this has been sort of this battle that they've gone back and forth with. But they're actually not eating enough calories. And specifically, they're not eating enough protein. So we always want to emphasize, protein consumption, making sure you're getting enough of that. Fresh produce, that's going to be huge. Unpackaged or unprocessed foods. Some people call it the anti-inflammatory diet. That's very trendy right now online. Before it was trendy, the Mediterranean diet, is another common term that was used. But it's essentially eating whole foods, unpackaged, unprocessed, with a focus on lean protein and fresh produce. Healthy fats are not bad. Nuts, avocados, things like that. Fruit in moderation, right? Because you're going to have that fructose component to it. But really, really, at the end of the day, most of my patients actually need to consume more, not less. The second thing I'll talk to them about is what is their exercise regimen. And again, there's a little bit of fatigue if there's sleep apnea that comes into play. There's a little bit of depression that can factor into that exercise journey. And so exercise can sometimes be a bit of a struggle for my patients. The other thing is that strength training is going to be super important to incorporate. So not just cardio, not just walking or running on a treadmill, but really making sure you're getting that strength training component. The strength training will drive that sugar into those muscle cells, helping with that insulin resistance component. So really, really important to talk about both nutrition, exercise, how's their sleep. I keep circling back to this. I have a good friend of mine, she's a colleague in the sleep space, and she talks about sleep as the fifth pillar of health, or the forgotten pillar of health, and really most patients with PCOS, if I dig deep, they actually don't have good sleep habits, or they're waking up, they have intermittent sleep, they sleep in many hours, they wake up not feeling rested. And so if we have the ability to correct that, we can really impact both the impact of their PCOS, how severe their PCOS is, as well as their likelihood for success, right? Because if you're oxygenating well, that's going to impact egg quality, that's going to impact your energy, so many other things, right? Your hormones, etc. So lifestyle is huge. And then toxin exposures, of course. It sounds really common sense, but I think in today's society, more and more we see that, vaping is socially acceptable, caffeine is socially acceptable. So these are all things that we want to be talking about. Aside from the lifestyle practices, when we look at the integrative medicine, we're also going to be talking about supplements. Supplements is a multi-billion-dollar industry here in the US, and it is not regulated. So it's really important that if you are incorporating supplements into your regimen, that you've talked to your healthcare provider, that you are trying to assess the supplement, its usage, the company you're getting it from. You really want to make sure that you're informed in that purchasing. In 2023, the International PCOS Network for the first time included supplements as part of the management of PCOS. Specifically, they named inositols as part of that management. And so when you look at inositols, there's typically two that are talked about, myo-inositol and D-chiro-inositol, and there are some companies that will sell them together in combination. Other supplements that you may think about would be things like CoQ10, which is a powerful antioxidant, berberine. You can look at vitamin D. Many of my patients are vitamin D deficient, and so doing that D replacement is helpful. There's many, Vitex, Sawgrass, Palmetto. I mean, the list goes on. I could name, several. And again, I think it's having an informed discussion with your provider about which one or which ones may make sense for your life. And then the third piece I like to talk about is acupuncture. I do not offer acupuncture specifically in my office, but I work with many acupuncturists in my area. They also have board certification. They also have training tailored towards different specialties. And so those that are trained in women's health and reproductive or hormone disorders can be a huge, huge asset to a patient's fertility journey and their management of PCOS in the long term. And then there are other things, right? So these are going to be more experimental, things like red light therapy, hyperbaric oxygen. So there are other integrative practices one can consider, but certainly at a minimum, I think lifestyle with all the things that we discussed, supplements with all the things that we discussed, and acupuncture are certainly worth exploring as sort of positive adjuncts to your journey. Yeah, so, I'm not a sleep specialist, so I definitely want to make sure people know that. So please don't take what I'm saying as medical advice, and definitely talk to your doctor. I think most people would agree that anywhere between 6 to 8 hours is probably, an average of what would be needed. And the important thing here is you want it to be uninterrupted sleep. And the other thing is that you want to make sure you're waking up and feeling rested, because sleep apnea may go undiagnosed. You may be sleeping 9-10 hours and you wake up feeling fatigued, right? And so just because if you have interrupted sleep, you're waking up a couple times a night, or you have a hard time falling asleep, or maybe you have insomnia, those things are definitely important to assess and evaluate. But even in a scenario where you're getting enough hours, if you are waking up and not feeling rested, that is also something that warrants talking, and exploring further. Got it. Okay, so I want to be very clear on one thing. PCOS as a diagnosis, Polycystic Ovary Syndrome, does not usually present with pain. It usually presents with cycle irregularity. Now, you can have ovulation dysfunction where you're getting these sort of sporadic ovulations, and in that ovulation dysfunction, you may develop a cyst. If that cyst ruptures, then you definitely want to make sure that you are seeing your OBGYN, that they're, helping you navigate that. But that really should not be any sort of regular occurrence. If you are having pain on a regular basis, then there may be something else going on. And I encourage patients to explore that. So the chronicity of the pain is definitely something that merits exploration and may actually be a second disease known as endometriosis that is compounding the PCOS diagnosis. Because PCOS in and of itself, remember, PCOS is not cysts on the ovaries. PCOS is an egg excess disease. One of the consequences of the irregular ovulation may be that at some point a cyst ruptures, but that is not something that should be occurring in any sort of regular fashion. So pain on a regular type of, monthly or bi-monthly or whatnot, that really should be explored as something separate from the PCOS. And it is not uncommon, by the way, to see PCOS and endometriosis going hand in hand together. Yeah, so I think number one, which I say this to all women, is really being an advocate for yourself, really not going by just what you're told, making sure there's been a proper diagnosis. I'll never forget my first year out of training, I had a patient who walked in and she was coming to see me for egg freezing. And yeah, I've been told my whole life that I have PCOS, and she had the typical sort of clinical presentation. And then when I went to go do an ultrasound on her, it turns out she had basically no egg reserve. So it was the opposite problem. She had had a very, very early egg depletion, early menopause, and no one had ever told her that. So really not going just by what you're told, but really understanding how the diagnosis was made and how the diagnosis is being managed. So really empowering yourself, being a self-advocate, I think is hugely important, particularly given how common this disease is. The second thing is to have a clear understanding about what you can control and what you can't control. So remembering that PCOS, at the end of the day, it is a medical diagnosis. It is not your fault that you have PCOS, right? But there are things that you can control. There are ways that you can optimize, right? And make your PCOS as manageable as possible. Most importantly, decreasing those risk factors for the future, right? The things we talked about, diabetes, heart disease, high cholesterol, metabolic syndrome, et cetera, et cetera. So really trying to early on get a good handle on the part of the disease that you do have control over. And then specifically related to fertility, I would say is don't wait. And what I mean by that is, once you're ready to have a family, if you know you have PCOS, then I would begin working with a fertility specialist. The earlier, the better. The idea there is that really, I don't want patients, because if you look, oh, you're 27, you're 28, keep trying, you're young, it'll just happen. And so some patients, by the time they get to me, they've been trying for a year, maybe 2, maybe 3, and the whole time their cycles were irregular, or the whole time they weren't ovulating in any sort of predictable fashion for them to be able to time intercourse. So once you know you want to start a family, then don't wait and just start working with a fertility specialist. The sooner the better. So I think the first one, again, is about self-blame and really understanding that it's not your fault. You're not any less of a woman if you don't have regular cycles. It's not your fault if you have PCOS and require help with fertility. Really sort of getting out of that cycle of self-blame and self-guilt. The second thing that I would say is understanding that there is a biological component to the depression and the anxiety. So yes, part of it is the stress and the toll that all of this takes on the patient, but there is also a biological reason why you are sort of more vulnerable to developing depression and anxiety if you have PCOS. And then the third thing is being proactive, getting out in front of the disease, like, okay, I have PCOS, I know I'm at increased risk for depression and anxiety, I know this is going to be a long journey for me, potentially, to try and get pregnant and have a baby. So what am I going to do differently? How am I going to get out in front of this instead of playing catch up 6 months down the road or 2 years down the road? For one, PCOS is a lot more common than people think. If you have a group of 8 or 10 girlfriends, at least one of you has PCOS. And number 2 is, that same thing that I come back to, which is a core belief of Ceibo, which is really empowering yourself and really understanding your diagnosis and your journey. Yeah, so we do have our office located in Fort Lauderdale, Florida. Our website is CeiboFertilityCenter.com, CEIBO. Ceibo is actually the national flower of Argentina, which symbolizes strength and unity, so it's very deeply meaningful for me when I chose that name. And then we're also on social media, so Facebook and Instagram. You can find us under Ceibo Fertility.